Thanks so much for joining us on this Tuesday after Labor Day. I was happy to get back to work. My kiddo school is closed, so there we go. So we had kind of an exciting morning. I forgot that it was closed, so we got that worked out. So here we are, do a good thing. So wanted to just say welcome to everybody. Really appreciate you being here. To our first Oklahoma City Provider Town Hall to showcase and introduce our plan partners. We're really excited to have you here. The provider community in Oklahoma is going to be so important to the success of this program. And so we're excited to have you here to ask questions, share your thoughts and insights with us, and get to know our plans a little bit better. So I'm Ellen Bittner. I'm OHCA's CEO, and I have here with me Traylor Rains, our State Medicaid Director, and Sandra Puebla, who is our Deputy State Medicaid Director. They are our all things guru for SoonerSelect. So we'll get into the details of this program a little later on. So we're really excited about this transition. This is a pivotal time in Oklahoma healthcare to really focus on enhancing and prioritizing our members, right? They're the focus of our business here at the Healthcare Authority. They're the focus of your business, your livelihood. So we're really excited to have this opportunity to prioritize primary care, focus on prevention efforts towards our patients, and really help them be that find the healthiest path that they possibly can. So thank you for being here with us today. I'm just going to run through a quick list of our goals in moving toward SoonerSelect, and then we'll introduce our plans, and then I will turn it over to Traylor to talk more details with you about our program. So we have a vision for SoonerSelect that is driven by 5 overarching, very specific goals. One, as I mentioned, our members are focused first and foremost. So we want to improve the health outcomes for Oklahomans. Our primary objective is really to enhance the health and well-being of our fellow Oklahomans. By shifting to our focus on prevention and primary care, we want to create a healthier population and elevate our state's overall health outcomes. Second, we want to move towards value-based payments and away from payment based on volume that has historically been the state Medicaid program. Providers will have the opportunity to showcase the great work that they're doing by entering into agreements with plans that really focuses more on quality measures and patient outcomes. Third, we want to improve Sooner Care beneficiary satisfaction. Again, a member-focused goal for us. So our members deserve the best possible healthcare experience. And so we plan to prioritize member satisfaction by streamlining access to services and promoting care coordination. Fourth, we want to contain costs through improved coordination of services. And fifth, increase cost predictability to the state. And while cost is not necessarily an overarching, really driving factor for us, that's going to be a benefit of this program. By coordinating medical, behavioral, dental, and broader healthcare services such as nutrition, transportation, housing issues, we can more effectively manage costs while providing comprehensive care to our members. So we're really grateful to have you here. I want to quickly introduce our plan partners. I know they're all over the room, so I'm looking for t-shirt colors and things like that. So I'm going to switch slides. First, I'm going to introduce our dental partners. First on our list, we have DentaQuest. You guys want to wave? Awesome. And you'll get a chance to hear directly from them and visit one-on-one a little bit later as well. Liberty Dental, who I see is sitting right here. On the medical team, we have Aetna Better Health of Oklahoma. I think they're the purple shirts over here. Humana Healthy Horizons, right there. Awesome. Oklahoma Complete Health, right there too. See, we're all friends and partners here. I love it. I love the coordinating colors too. The pink and purple, very happy. And then our children's specialty program contract is also held by Oklahoma Complete Health. So that program will serve our most vulnerable kiddos to provide behavioral health, physical health, pharmacy care to kiddos who are juvenile justice involved or involved in the DHS system, including kids who are receiving foster care or adoption assistance. So the plans were selected through a highly competitive bidding process that ensures SoonerSelect is managed by the best, by the highest quality, effective, qualified, and specialized organizations that have the experience to make these programs a success. So one of the last things I want to mention to you before I turn it over to Traylor is just how much we are excited about the proactive, preventive primary care efforts that are going to be accomplished through this program. So as you're aware, under the legislation, it requires 11% of the medical spend to be spent on primary care. That's close to triple what we do now. So we're really excited about that opportunity to reach patients at at the entry level to help prevent future chronic diseases and give them a better quality of life from the get-go. So one of the other things that we're excited about in Oklahoma that makes us unique, while managed care is not a new concept around the nation, we're one of the last states to make this transition. What's unique about what we're doing is having providers at the table. All the plans that were selected are provider governed. They have everyone from behavioral health specialists to hospitals to primary care physicians. So we're excited to have the provider voice at the table. You know your patients best. You know what you need. Oklahomans know what Oklahomans need best. And so we're really excited to have all of you here. Really grateful for your participation in this from both a governance and a service perspective. So thank you so much for being here. And I'd like to turn it over to Traylor.
Thanks, Ellen. Good morning, everyone. Love to see the great turnout here. So what I'll do is just kind of start by giving you an overview of the basic premises of SoonerSelect. Ellen gave a good overview of why we're going this direction. I trust that everyone attended our town halls in the fall, so I don't need to go into a lot of detail. But I will start with what's the overall program design and what's it going to look like. Whoa, very sensitive clicker. There we go. Okay. So we have very high expectations for all of our contracted entities. We have the request for proposal that ended up being the contract document as well over 500 pages, which is just a lot of requirements because it's important to us that as we go down this path that we're not handing over the keys to the castle here with the Sooner Care program. Rather, we're partnering with folks to help us deliver these services. And it's our job as the healthcare authority to ensure that there's proper oversight and compliance activities. So some of the basic expectations that we wanted to make sure, the first one is timely payment to you, our providers. So one of the hallmarks of the Sooner Care program at the Healthcare Authority is that we pay weekly. That was a big deal when we instituted that, and it's still a big deal, and we want to maintain true to that. So we will have a requirement that once a clean claim is submitted to one of our contracted entities, that payment will occur no later than 14 days. We know currently it's 7 days, and what we're seeing from our plan partners is it's more than likely going to be 7 days or even less, depending on the plan. The same goes for timely response of our prior authorizations, just as similar as payment. We want to make sure that our members ultimately are being served and they're served when they need to be served and quickly. And so we have very tight timeframes around prior authorization, depending on the type of service and whether or not that service is urgent or emergent. Also, quality metrics related to improved health outcomes. We have very specific things that we want to achieve in the first 5 years of the program related to our members' health. And so we have baked those requirements into the contracts that we have with our contracted entities. We give them very specific glide paths to reaching those outcomes with our members, and they will be incentivized or penalized for not meeting those. As Ellen mentioned, we require the contracted entities to spend 11% of their medical care on primary care. We are working on we're developing currently what primary care means though, right? So it can have a very broad definition, but we want to make sure that it's those, that our members' needs are being met without having to go in an emergency room or an urgent care unless they really need it, but that we're addressing all those primary care needs and incentivizing our plan partners and our providers to work on that. So a streamlined provider portal. One thing that we heard a lot the last time as we went through this past, what we're calling our dress rehearsal in 21 was the administrative burden to you, our providers, of going to multiple plans rather than just contracting and billing through the Oklahoma Healthcare Authority. One of those things that was important to us this time was to make sure that we reduced as much as we could that burden. And so one of those requirements is that our plans all agree to work together to use a streamlined single provider portal. So that means you would have one place to go in and choose among the different plans, submit your billing, submit your prior authorization requests, check eligibility. So you're not going to multiple windows on your in your computers to enter this information. Along that same note, we also are requiring a centralized credentialing process such that you don't have to do completely different processes for each of our plans. They've all agreed to partner together, that's medical and dental, to use the same credentialing verification organization. And so that should hopefully remove some of that burden for you guys. The other really important part here was the rates and the rate floors for the first 2 years. Another thing we experienced last time was we know there's a fear and honestly an overall misconception of when managed care comes into a state. The thought is, well, they're going to either raise all the prior authorization guidelines and criteria to make it impossible to get something covered, or they're just going to come in and slash our rates. So because of that, there is a requirement not only in the contract, but also legislation that there be rate floors for the first 2 years. So the plans cannot reimburse on a fee-for-service basis any less than the current fee-for-schedule rates at the Oklahoma Healthcare Authority. Why 2 years? We wanted to allow a glide path for our providers to enter into value-based agreements with our plans, and we know that doesn't happen overnight. We know that you need a reasonable time to understand how to do that, work with those plans, work with the healthcare authority to actually enter into that. So we wanted to ensure adequate rate payment and reimbursement during that time. So who's going to SoonerSelect? Not everyone in the program is going. There's going to be about 2 or 3 slides on this, but the long and the short of it is everyone except the aged, blind, disabled, home and community-based waiver population, long-term care, nursing facility, everyone but those folks are going to SoonerSelect. So our adults, our pregnant women, our kiddos, as we mentioned earlier, as Alan did, the children's specialty plan will cover those kids in child welfare services as well as juvenile justice. Our American Indian, Alaska Native population will be voluntary. So they can opt in to SoonerSelect, but they are not required to. Again, the excluded, I left out our dually eligible. So if you have Medicare and Medicaid, you'll also be excluded from SoonerSelect. And that's actually baked into the legislation that asked or required the healthcare authority to go towards a managed care model. So any changes to these populations would have to go through a legislative process. Covered benefits. Again, to summarize on this slide is if we cover it now, it'll be covered as in under managed care. The only difference is there's an opportunity for our managed care plans to and our contracted entities to add what's called value added benefits. Those things that can affect over a person's overall health that are not necessarily treatment related, but affect those social determinants of care that we know contribute to health factors outside of just seeing your physician for primary care visit. We're also incentivizing partnering with community-based organizations and social service providers, employing or partnering with community health workers and other non-traditional healthcare workers that we know, again, impact individuals' overall health, but we just, as a Medicaid agency in our current environment, are not able to cover. Another important thing here too is to recognize that pharmacy benefit will be included in SoonerSelect, but the healthcare authority is still responsible for the prescription drug list, as well as all of the rebates that come from that for the prescription drug program will still accrue to the benefit of the healthcare authority, not our managed care plans. And I will say all of these slides will be available as well as the recording. So if you want to go visit and spend more detail on these slides, again, the real value of today is for you to meet our plan partners afterwards and have those dialogues and to be able to answer any questions towards the end. So again, one of our overarching goals is quality of the population that we serve. So overall population health. Put your glasses on, this is going to be small, but we updated this slide since our last town hall because we have an update to provide you. So we have, per the legislation for managed care, we established and the healthcare appointed a quality advisory committee. So we have around 15, 16 folks that were appointed to this. We had an open application process soliciting folks that were interested in serving on this committee. That was back in the fall. We interacted with a lot of provider and trade groups and associations to solicit their input around this. And so we had a lot of folks interested. And so after vetting and making sure there's no conflicts, after we made our managed care awards, the folks on the slide are now our quality advisory representatives. And so this group at first will meet at least bi-monthly. I'm currently in the process of setting that meeting up now. It'll be chaired by myself and our Chief Quality Officer at the Healthcare Authority, Chris Radley. So excited to get these folks together and start working on going through the quality outcomes that we're requiring for our contracted entities, really helping the Healthcare Authority to keep and hold our managed care partners accountable to meeting those health quality outcomes. We also have various supplemental payments that we're transitioning to state directed payments, which are going to be tied to quality and outcomes. And so really leaning on this group of providers and stakeholders to help us build out what those outcomes are going to be, how do we reach them, making sure they're holding the healthcare authority accountable, and how we administer the program as well. So the folks on this committee are not in a silo. They're not in isolation. They represent you. They represent your provider types a lot of times. So we will encourage them, much as we do with most of our advisories, like our medical advisory committee, that reach out to them. We will more than likely provide contact information or a way for you to get a hold of them so they can be your representative at that table. They are open meetings, so anyone is welcome to attend, provide public comment, and there will be minutes from the meeting so that folks can have access to that. So speaking of state-directed payments and supplemental payments, most of you in this room are probably aware that we have our SHOP program, which is our Supplemental Hospital Offset Payment Program, which essentially is just a supplemental payment to our hospitals. So through Senate Bill 1337, outside of our traditional hospital supplemental payment, there's also created another pool that's around $100 million that is going to be directed towards community providers. So it's a way to really supplement, increase access, get additional cash flow and revenue to our community providers who are, again, the lifeblood of our program and see the majority of our members, but attaching that to quality outcomes. So if you are a primary care provider, for example, you may have experience with our SoonerSelect program, which is part of our medical home. It's going to be similar to that with different outcomes measures, more opportunity for providers to participate, like mental health and other specialty in the communities. So we're currently working through what that's going to look like, how that will be distributed, and what those outcome measures will be that it'll be tied to. Again, something that our quality committee will have good input into. Timeline. This may be our shortest slide. So right now we are anticipating launching our programs. Dental is expected to go February of 2024. And it's not a joke, but April 1st of 24 is when we will go live with medical. It's just the way it's timing out. I hate April Fool's implementations, but it's the way it is. And the difference in launching for different times there is we started the processes on two different tracks between dental and medical. We went a little earlier with dental, really, and that allows additional bandwidth at the healthcare authority to contract, do the RFP process, make those awards, and then kind of have some in between time as we implement the two plans. All of this is contingent on CMS approval. So our federal partners, the Centers for Medicare and Medicaid Services, approve every step of this process, from the contract to the rates that we're setting. We have to go through a very robust readiness process. It includes site visits. It's a large team that goes through the policies and procedures that are submitted by our plans. So we want to make sure that is all set and ready before we send a member notice out. The last thing we want to do is send a notice to our members about a plan that's coming and then have to pull it back because we weren't ready. So we've set internal go, no-go dates, and we intend on keeping you apprised of that as we go along. All right. So briefly, because I recognize I was told I did this wrong last time, I wanted to take a second to introduce the CEOs of the plans and allow them just a minute or so to introduce themselves and their plans. And their mission, values, and goals. So I will start with our dental plans. I will see Shane from DentaQuest. Are you in the room? There he is. Christine will bring you a mic. If you could just introduce yourself, your plan, and then we'll go down the line.
Hi, everybody. I'm Shane Patrick with DentaQuest, the Oklahoma CEO. We're just glad to be here today. Please come out to the table afterwards, answer any questions for you guys, and just glad to be here. Thank you so much.
Thank you, sir. And Lisa Gifford with Liberty Dental.
Thank you, Simi. Hi, I'm Lisa Gifford with Liberty Dental, and our focus is really going to be on primary care and making sure that we have utilization. That's going to be really important to us. We know that in Oklahoma, dental care usually takes a back seat. And so it's our goal to put that on the front seat and try to get people in, get that dental care before it becomes a dental emergency. Some of our value adds are really around conditions. So we have some value adds around diabetes with our pregnant moms, and just ways that we can keep people from having dental surgeries. So that's kind of our goals.
Thanks, Lisa. All right, to our medical plans, I'll start with Aetna, Dr. Sonia Hughes.
Thank you, Trailer. Good morning. I'm Sonia Hughes with Aetna Better Health of Oklahoma, and I'm joined today with a few members of my team. We have members here who are from our provider relations and networking team. We have people from our social determinants of health community cares team. And I'm very excited to say that we have Brittany Stokes here from the Tulsa Girls Home, who's one of our governing body members. As Trailer mentioned, we are a provider-led entity. So we're glad Brittany is here with us today. We will be glad to visit with you in the lobby. And of course, our goals align with the goals of the Oklahoma Healthcare Authority. We know that providers are also an important part of this. So we're we will partner with you and support you. And as a provider myself, I understand that this change can be a little scary. And so we want to be there to support you, and whatever we can do to help, let us know. We're glad to be here, and we're very excited to take care of your members and Oklahomans.
Thanks, Sonia. And with Humana, Joe Fairbanks.
Ways over there.
I know.
I actually asked my colleagues to clap for me when I was announced, and they didn't do it. We'll talk later. Good morning, everyone. I'm Joe Fairbanks. I'm the CEO of Humana Healthy Horizons in Oklahoma. Very good to be with you guys again. From Oklahoma, raised here. I was going to say born and raised here, but that would have been a lie. I was born in California, moved here when I was 18 months old. So I say I'm from Oklahoma. One of my very first professional jobs was working at the Oklahoma Healthcare Authority. Trailer was my first boss. Thanks, Trailer.
Still your boss.
Yeah. And so nothing's changed in my entire professional career. Trailer still, he's followed me for 10 plus years, 15 years. Very, very excited to be here, answer all your questions. I have with me Mary Miller, my Director of Health Services. So anything related to health services you'd like to ask us, please come speak with Mary. And then I have Christy Lawrence, my Director of Provider Contracting, which is probably the person you actually want to see rather than me. So she's here to answer all your questions as well. As Sonia said, our goals align very closely, exactly with the Oklahoma Healthcare Authority, and we're very much looking forward to partnering with all of you to serve the SoonerSelect population as best as we can. Thank you.
Thanks, Joe. And I'll introduce Clay Franklin with Oklahoma Complete Health.
Okay, good morning, everybody. Clay Franklin, Oklahoma Complete Health. And as much as with Dr. Hughes, I come from the provider world, so I do know how the anxiety and not knowing how everything's going to happen, and how everything will be implemented, just the anxiety that creates and uncertainty and the unknown. With Joe and Sonia, we're all from Oklahoma, which is really good. And I will say the three contracted entities on the medical side, we're working very closely together. As Trailer mentioned, like the credentialing, the provider portal, because we understand what it's like from the provider side. So we're trying to make it easy as possible with all three of us trying to work together versus having bifurcated processes. Like the other two plans, we're also a provider-led entity. I have a board of directors. It's chaired by a provider. My vice chair, my secretary are providers. 8 out of my 10 members are from the provider community. So we're truly a provider-led entity and really focused on how to do this right in Oklahoma, and we're focused on, from a provider, there's 2 things we need to do is pay claims accurately and timely. And that's the key thing is from your world, that's what you got to have. And that's the bare minimum. The discussions we're having is how to improve health outcomes. So these are the discussions we do want to engage in contracting when we start getting data back from the healthcare authority to find out how can we partner with you with value-based, because there's so many things providers can do with the patient that you're seeing to improve those health outcomes. And we have different models and we can tailor it, but things that the provider could do to shared savings with that provider and really make it a win-win situation. So this is kind of the discussions that will evolve into that. And it's not a cookie cutter approach, but really it's for each clinic, for each provider, how do we do that? And just having those kind of discussions on that respect. But we look forward to working with everybody. Our goals obviously are aligned. And our contracting folks are here and our provider relations individuals are here as well. So we look forward to speaking to you more afterwards. Thank you.
Thanks, Clay. And I'd be remiss if I didn't introduce our SoonerSelect team as well. Of course, it's an agency effort. It's taking everyone in our agency to do this monumental shift, but I want to introduce formally Sandra Puebla as our Deputy Medicaid Director. And so she's over the SoonerSelect project as a whole, and then hiding in the hallway, but you probably saw them as you signed in, is Michelle Stafford, she's our Director of SoonerSelect Operations on the medical and children's specialty plan side. And then Stephanie Mavredes is our Director of SoonerSelect Operations on the dental side. So these folks will have a large team working with them as we not only focus on implementation efforts over the next 8, 9, 12 months, but also on an ongoing basis and looking at all those hundreds, if not thousands of reports that we're expected to get from our contracted entities on a monthly and annual basis. So I will pause there and allow for questions and answers if you have them. Yes. No, you're good. So Mike.
I'm from a dental provider's office. I've worked there 30 years, so I've been through all kinds of changes with Sooner Care. We've seen Sooner Care patients the entire time. My question is, since obviously what we're used to again is that centralized provider portal, which is awesome. That's scary to me to jump out of that. So hopefully that transition is simple. My question is, since we're going from one payment, it seems, entity process through the healthcare authority themselves, now going into February of next year, two separate possibilities of payers, but yet still in a centralized portal. How does that shake out as far as who pays what? And I guess I'm not understanding the multiple entities of payers and how that affects through just one central portal.
Sure. So essentially, all of your payment, your prior authorization processes will be through our two dental plans, our contracted plans. You'll still, as a provider, come through the healthcare authority for your provider enrollment and your screening. So you will still be the front door for that. From there, then you'll go through a centralized credentialing process. So whereas we may screen for 4 or 5 elements, you may have to screen for an additional 3 or so to be credentialed with their plan, because there's certain accrediting requirements that they are accountable to, like an NCQA, for example. So that process will be streamlined as much as it can be. And then through the portals, you will submit your billing, and it'll come from, depending on where the member is a member of. They're still a Sooner Care member, but they may have their plan through, you may have some with DentaQuest, some with Liberty. So they'll streamlining and aligning as closely as we can. Kind of going back to the prior authorization requirements, none of our plans can be more restrictive in their medical necessity criteria than we are today. So there shouldn't be a lot of guessing games around, am I going to get approved for DentaQuest and Liberty the same way? Because they should have very similar prior authorization requirements. But the goal there, there's still going to be some elements that are a little different between the plans in terms of value add, and maybe the look and feel of the portal may be a little different, but we're trying to streamline as much as we can. What we've done kind of too on the provider portal is an analysis of, if they're bringing 2 different products in terms of a portal to the table, what's best for the provider? Is it best to streamline that in one way where you lose a lot of functionality, or can we make it as best as we can, especially on the dental side, to bring years of experience in portal development that they bring to the table? So we're trying to do that in a way that is, we're not just using OHCA staff to view that, but we're also trying to focus group that with some providers to make sure that all of this is human-centered and it's designed and it's focused around our provider community. Does that help?
It's associated with the patient's plan themselves individually,
right?
Not associated with us trying to filter who goes to what.
Correct. That's attached to the member. So the question, if you couldn't hear it, was, is the plan attached to the member? And yes, so the member will have choice. So we're required by federal law to have 2 plans at least. So we're going to have 2 dental. And the member's ID card will be specific to the plan that they are served by. So if they have their card on them, it'll say Liberty or DentaQuest, and then you know which portal to go into or which drop down to access in the portal. If not, when you check eligibility in the OHCA portal, as you would now for eligibility, it'll say what plan they're affiliated with. So it'll take the guesswork out of it there. Correct. Yep. And it'll be co-branded. So it'll have the healthcare authority or Sooner Care logo on it along with our plan partner. Sure. I see one in the back. I don't know who was first though.
Yes, I was wondering, is the centralized portal going to be available February 1st? Or is that like down the road kind of thing?
That's what we are planning for. Yes. Yeah. Whoever I saw red. Yeah.
Copays change per plan, or will they still remain the same if it's going to be $4 if they come from a managed care? If it says that there's a copay on the, and then if it's not,
Copays will remain the same.
okay,
Yes.
so will they be required to carry cards now then? With their
we-
identifying,
We always
plan?
recommend, so the copays will be as they are today. So for specialty and primary care visits for the population, and the same
because
exemptions
I
would apply.
know they quit making cards for a while.
Right. Well, we allow our members to print their cards off, but our plans are required to make actual
Right,
tangible cards for
right.
our members. So they will have those.
Okay,
Currently, you have to look up on the Sooner Care site to see if these people have a copayment or don't. They're all different. That's not accurate. And it, well, 100%. Yeah, and it doesn't, if you have, your EHR is not able to verify eligibility. I mean, we have to look up every single person online every day. As a real thing.
Thank you for your comment.
I'm in behavioral health, and so we have a lot of therapists that are under supervision. Are all these plans going to continue to be able to pay if you're okay?
Yeah.
Okay, thank you.
Whoever our contracted network is now will be covered by our plans.
Hi, my name is Casey Blackwell. I'm a pharmacist. I represent about 300 community pharmacies across the state through a company called AlignRx. So I have some questions about the pharmacy benefit. You mentioned the OHCA will continue to maintain the drug list. All the rebates will go back to OHCA instead of managed care organizations. So kind of like the question about copays, will the copays be standard across all plans?
Whatever the copays are today will be also through our plans. So
Okay.
copays are actually federally mandated with limits, and then the states can go up to that limit. So whatever we've chosen as a state, that'll maintain. Now, there may be instances where a plan for certain services decides not to charge a copay. That might happen. We'll have to check with them, but otherwise.
So it could be a lower copay, but not a higher copay.
Correct.
What about the pharmacy payments? Are those standard across plans, or do those plans get to choose how much the pharmacy is paid?
That would be the rate floor. So for at least 2 years, all rate floor across all services will be in effect.
Okay. And then does each plan have a PBM they're contracted with? And do the pharmacies need to contract with that PBM, or do they contract through OHCA?
I don't know. I think we have plans. I think it's a plan PBM, but let us follow up on that to be sure.
Okay. And then you mentioned quality measures and quality incentives. Can you give us, are those quality measures? I know that they're not all specific to pharmacy, but are those available yet, or are they still in process determining what the plans are going to be rated on for quality measures?
It depends on which the measure is. So I will say within the contracts that we have with our plans, there are certain glide paths to we ran certain baseline data around certain measures, mostly HEDIS measures, and then we're required a certain minimum of that over a 5-year period. And so that's in the contract with them. That was in the publicly RFP document. Now the measures, for example, for like the primary care supplemental pool, those aren't final yet, but we expect those to be presented at that quality committee that I mentioned and finalized through that group.
Okay, thank you.
First one in the back. Okay.
Hi, this may have already been talked about previously and I'm kind of late, but in regards to like DME for like your Advantage, people on the Advantage program or Title 19, how is that being changed or?
So if you are being served by the Advantage waiver program, you're not going to be in SoonerSelect. So the process is applicable to DME for those members will stay exactly the same. That'll still be administered through the Healthcare Authority and our operating partner, Human Services. This will only be if someone has Title 19 only.
And so for DME or say incontinence supplies, those would have to go through this new process as well.
Only if the member that you're serving is not on that excluded list. So if you are, let's say you have an expansion member on your panel that you're serving and providing DME for, that would go through our SoonerSelect partner. If you have someone that's being served through a long-term care waiver like Advantage or the DD waiver, that would still use the same process as we use today.
How does this affect the health information, excuse me, health information exchange fire data program that you already have in process?
So there have been changes to the HIE rollout. It is now, you can submit an exemption. So I'll start off with saying they're two different things, but good question. So the HIE, we're allowing members or providers to enroll in the HIE and sign up to use that and submit and receive data. You can apply for an exemption to that, which is on our website. If you apply for an exemption, you'll be granted the exemption. If you are a part of the health information exchange, then our managed care plans will utilize that data and marry that with their encounter and claims data as well, and then submit that to the HIE if you are a part of that network. Does that help? A little bit. The question was, is there any financial assistance for the HIE? Yes, there is a grant program and those criteria being established. I think we're going to talk about that at our medical advisory council meeting this Thursday, and that will be on our website as well.
I just had a quick question circling back to the one portal situation. So does that mean payment will come through the one portal? So are we looking at one payment or separate payment per entity that we contract with?
So as you can imagine, we're still in development. And
Right.
so we're not exactly what it's going to look like final. But what I will say is when you log in, it should look like the same on the first page. And then once you understand the member's eligibility and who they're affiliated with, let's say since they're behind you, if it's a Humana member, there will be a drop-down box in this portal where you choose Humana, and then it'll take you through their portal where you can submit a prior authorization, submit billing, and it'll all come through that process.
You mentioned the centralized portal earlier. With the centralized credentialing portal, though, when do you expect that to go live? If that goes live in February, obviously there's going to be some delays and other issues associated with that.
That is actually a great question because we know that you'll be talking to these folks later and trying to enroll and what that's going to look like. We're working on that with the plans. And I will say, just as a kind of a sneak peek behind the curtain of the process here, is that when we meet with the plans, we meet with all of their subject matter experts as a team. So the OHCA team meets with the implementation team from all the plans at the same time. So we're saying the same thing. There's a lot of reason for that, but mostly so we're all saying the same things to y'all and making sure that you're at the front and center of this. So we have all recognized that it may take a second to get that process up and going because those things take time and to agree upon. But we're working on what's that intermediate or that stopgap solution to still ensure that it's as easy on you as possible in year one as it is in the following year. So we'll keep you updated to that. And I would love, this goes for everyone. If you encounter something with our plan partners that doesn't feel right, or it's kind of not aligning with what I'm saying here, reach out to us and let me know so that then we can make sure that we're all kind of swimming in the same direction. Because understandably, we're doing a lot pretty quickly and things may go off left a little bit. We'll bring it back to center. So if that's not your experience as a provider, as what I'm saying today, please give that feedback to us. Yes.
Good morning. My name is Stephanie Valentine. I'm the owner of Therapy Link Solutions. We're a pediatric therapy center located here in Midwest City in Oklahoma City. In the past, when we have had to add new therapists to our practice, the credentialing process with Oklahoma Healthcare Authority has been relatively quickly, and we've been able to get them to work within a matter of a week or two. With private insurance companies, that credentialing process can take up to 90 days, if not longer. What type of credentialing timeline are we looking at as we add new employees to our practices?
Great question. I will say that the healthcare authorities process will still remain relatively the same in terms of screening and enrolling. And those providers who are successfully enrolled with the healthcare authority will then be considered by the plans for credentialing. It could vary among the plans, and I believe we have a contractual requirement for a certain timeline that I'm forgetting at the moment, but it may be a little longer, but we can work through those on a case-by-case basis too. And I encourage you to ask our plan partners when you talk with them in a little bit about what their timelines for credentialing are too. That would be right. So the question is, can they continue to work under supervision while they're awaiting the credentialing process? And I don't know off the top of my head, but we can get that for you. And I would, again, encourage you to ask the various partners what their process is too.
Good morning, Trailer.
Hi, Lisa.
I'm in behavioral health. Been around for a minute, so I've seen managed care in various forms. I'm excited that there is going to be a centralized process. One of the things that has been an issue in the past is the prior authorization and requirements, especially needing physician signatures, things like that. Do you foresee the PA process changing in any way, or is that going to be pretty consistent with what we have now? And will that be across the board?
So it should not be, we will ensure that it's not more restrictive in terms of criteria. Now, I will say that behavioral health authorizations are a little unique outside of the medical, and that we currently partner with a sister agency, Department of Mental Health and Substance Abuse Services, who has a process that is not only a prior authorization process, but a data collection mechanism as well. And so we are working with the plans to make sure that we're still able to collect that data and that the processes remain similar. But there may be a different look and feel as you go through the single portal and are directed to each of the plans. It's actually something that we're currently working on in our work groups, along with the DMH and our plan partners. So all that to say, the look and feel will be a little different, but in terms of what you submit to get the authorization, should be very similar.
I have a few questions. First, you said there were some excluded members, and the process would be the same for them. So basically when you go in and you looked up their eligibility, it just says Title 19 only. That means that you're still using the old Sooner Care portal for.
So the portal, not necessarily. So essentially, if you have your Sooner Care benefits because you're age blind disabled, or you have Medicare and Medicaid, or you're being served by like the Advantage program, you'll not be served by SoonerSelect. But when you check eligibility in the OHCA portal, it'll tell you if you're a SoonerSelect member or if you have your eligibility through another way.
So will we know where we are supposed to go if they are one of those excluded members?
Then current processes stay the same.
Okay. And then you had mentioned that some of these providers can add value benefits. How will we know what the value benefits are and how will those be communicated to us?
Great question. So we have a SoonerSelect website that is up and running that we will continue to build upon as we go through this process. Right now, we have received the various benefit designs from our plans, and we're working on publishing that on our website, because it'll be important for not only our providers, but our members to know what those benefits are when they're choosing a plan to begin with. So we'll have a benefit comparison guide that will go out to our members and will be published on the website. So you can see exactly and compare plan to plan, much as if you have commercial insurance, much as the process is when you're choosing among those plans.
And also for attachments, like currently in the dental world, we don't have to send in x-rays, stuff like that. Are there going to be attachment requirements with the new providers?
I will defer to our dental plans when you speak to them on that one. I'm not 100% sure right now, but they will be able to tell you.
Sir, where does routine vision fall in all this?
It falls as a covered benefit under the program.
For the ones that are 21 and older?
Whatever our benefit is now, we'll maintain that level of coverage.
There is no routine vision for 21 and older.
Okay. Then that's
now the under 21s still have the Title 19?
Yes. Our covered benefits will remain the same unless a plan chooses to add coverage for a population that we don't currently cover.
Okay. What about the ones that the Title 19 ones, they get in there and they've got a medical problem? Now, do we have the option to refer them out to provider we want to use, Or do they have to go out to a provider that you guys are in networked with?
How would you do it today?
How do we do it? We'd refer it out to somebody that we trust and know close to where those people live.
If we don't have a covered benefit for someone, so I will say this is a current OHCA process that's not changing as we go to SoonerSelect. But as it stands now, if we don't cover a benefit, you can refer a member so that they could pay on their own to a non-Sooner Care provider. But if it's a covered benefit and we cover it, you have to send them to a network provider that we would pay for.
Will we use the OHCA referral form for everything, including these new companies that we partner with?
The question was, will you use the OHCA referral form? Are you speaking like the medical home referral form?
Correct.
No. So you will use whatever process the contracted entity has through the single portal to refer to specialty care, for example, if that's your question. I'm sorry, we have to have mics in an ordered part of the Q&A process, but we will make all that as streamlined as possible.
Hi, I'm Sonia Coleman with Emergency Medical Services Authority. We are a ground ambulance company here in Oklahoma. We serve more than 1 million patients. My question is regarding non-emergency transports, because we do emergency and non-emergency transports. So with the contracted entities, how will non-emergency transportation be coordinated? Will they have multiple vendors that they then subcontract with, and will we have to deal with those multiple subcontractors?
The answer to your first question is NEMT will be administered through the plans for the members that are in their covered population. I actually don't know who their current vendors are. I've heard some might use the one that the Healthcare Authority currently uses. I will say that we are going into pre-procurement on that, so ours may even change or may stay the same. But there is an opportunity for different contractors in that space, I would say, depending on the plan.
Okay, so if there is an opportunity for multiple contractors, that adds more administrative burden on us, because then we have to go through not just 3, but possibly, 6, 9, 12 vendors.
This is a great question for the plans to ask them who they plan on using and how that process is going to look for you as a provider.
Okay, so I guess what I'm trying to figure out is, will OHCA help manage that process to ensure that there is some synergy, I guess, so that way we don't have to deal with so many multiple providers?
We will oversee the program and monitor for compliance and lean in where we can and it's appropriate to make it easier for the provider. It's going to vary depending on the exact situation. But yes, I encourage you to talk to the plans first, and then based on any feedback from that, feel free to reach out to me and we can talk through it, and I can talk to all the plans.
All right, thank you.
Hi, I'm Jody Jennings from TheraFund in Norman. We provide OTPT and speech. I heard you say that it was a federal requirement that you provide 2 plans to provider or 2 members?
At least.
Okay. So with children, is there only 1 plan complete?
They're for children in the custody of the state, either through Human Services for Child Welfare or Juvenile Justice. There's 1 plan.
Okay.
And really, it's 1 plan because as the custodian, the state is the custodian of that child, and they're choosing to put the child in that plan only because it's more intensive wraparound type care coordination specific to their needs. All other children outside of that still have the choice of multiple plans.
Okay. Thank you.
Is there still a plan for, I know that there was talk at one point, as far as building maybe a bridge to OSIS to be able to report immunizations for the state website, since now that we're privatizing and having several different plans, is that still in the works, or is it going to be individual per payer? Or
I don't know. I can follow up though with my team.
Okay.
As far as prior authorizations and things like that, when February comes, are we going to have to reapply for a prior authorization with these 2 new companies, or will the original one still work?
So I know that there will be a continuity period. I want to say it's 90 days I'm seeing head nods. Thank you, Melinda. There's a 90-day continuity period. So if you have an authorization that's open with us, it'll transition to the plan. But at that point, they will be working with you to obtain new authorization with new processes so they can maintain knowledge of the utilization of that particular service. But there will be a transition period.
As overwhelming as this is for us, I can imagine what it will be for our members. And part of what we have been doing to be helpful to them is to help them, get their Medicaid and enrollment and things like that. So my first question is, how is this information going to get to our members in a way that is going to be easily understood and comprehended? And secondly, what is our role then when they come in and they may be confused? Because obviously, we're a part of a network to be helpful to them, but just what is our role in that? Because we obviously can't say our preference is this or that. So can you just help us navigate that a little bit, or what you envision?
That's a great question. Also at the top of our forefront of our brains as we go through this process, we know that SoonerCare members have been through a lot of change in the last 3 years, especially the year we're in. As we go through our public health emergency unwinding, there's a lot of letters and information going to members. Some of it's being seen, some of it isn't being seen. We're trying non-traditional ways to communicate and really do a lot of outreach regarding that. So we know now to bring on, and we're moving to managed care as we're unwinding and going through all this. It's, as you can imagine, it's provides a lot of difficulties from a communication perspective. But we will have outgoing mailers to our members, telling them about the enrollment period, explaining what that means, giving links to our choice counseling website that has the benefit plan design and compares all the plans. We're also pivoting some of our tier 1 and tier 2 call centers to be more of a choice counseling broker, so that, a lot of times we have members call in now saying, what's my covered benefit, or how do I obtain eligibility, or they questions about eligibility in general. We're retraining that workforce to now to provide information about the various plan options and opportunities. Those folks are not there to give recommendations or guide to a certain plan, but rather to inform and provide information and answer questions about basic benefit design so the members can make an active choice. Now, that being said, we know nationally that less than 20% of members in states that do this actually actively choose their plan for the first year. And so there will be a level of a very basic round robin auto assignment to a plan if a member or a family has not chosen during the enrollment period. If a member, and we will look at things in that algorithm like maintaining families together in the same plan, making sure that their most recent primary care provider is in network with the plan that we're assigning them to, among another host of factors. But then once they get notice that they have been assigned to a plan, there's also another period of time, I want to say 60 days, to where the member can say, you know what, I went and actually looked at that benefit design, and this other one is better for me and my family. At that point, they can choose another one based on that information. And then once they make that next choice, then they'll be locked in until the next open enrollment period. But yes, as providers, we are working on communications toolkits. If you have helped us with outreach with a public health emergency, you may be familiar with what our toolkits look like, to where you can do point and click signage for your offices, giving them direction to the toll-free line for them to call for choice counseling. And we're not going away. So our member services will still be available to answer those questions as well. Okay, there's just 2 more questions.
Bill for those services as duly eligible just by having Medicaid, they just apply for a Medicaid number and have that. Is that right?
Yes. So the question, as I understand it, is if you are dually eligible, meaning you have Medicaid and Medicare, how does that impact you? So nothing changes for those members. They will not be required to, nor can they opt into a SoonerSelect plan with one of our partners.
So the providers that don't have to, if they choose not to be in any of the managed care plans, they can still be paid for the dually eligible members.
As a provider, yes. If
Yes.
you, so yeah, if I as a provider only see Advantage waiver members or duly eligible members, there should be no reason for me to contract with a plan because all your payment will still come through the healthcare authority.
Okay.
Now, I say that we recognize that there's going to be transitions of care, right? So I might not be disabled today, but God willing, I'm not, but I could be disabled tomorrow. So there's going to be a transition of care period where I'm going to need my plan to transition my care to an Advantage waiver or another service. And there may be some overlap on like a single case type arrangement, if that makes sense.
Okay. Sounds like there's a
That
lot of
should not be
potential
routine.
questions still. Yeah. Okay.
Okay, one more question.
My name is Laura Ruiz and I work for TheraWest Physical Therapy. I am the medical billing director. We have multiple offices currently. We're running 3. We're out of a rural Western Oklahoma, kind of making our way east. I have 2 questions specifically. One is, I believe one of the beginning slides stated that the authorization period would be like in a timely manner, things like that. Currently, we're running 3 weeks from the current initial evaluation period. So within the 3 different providers, or excuse me, insurances that are available, will that period become more timely? Like I said, I mean, we see children, adults, disabled.
You're a therapy provider? Is that,
Yes. Yeah, physical therapy. And so we're running 3 weeks after a surgery, whether it be an injury or just kind of a reoccurring thing. We're running 3 weeks after our initial evaluation to get someone actually seen for their care. Will that be kind of more streamlined, more timely?
Yes.
Okay.
So I will say that we don't always hit the mark currently at the healthcare authority, and therapy authorizations is something we continue to strive to be better at, and we're working on ways to do that. But this is a place where we're holding our contracted entities to a tighter standard than we currently have for ourselves. And so, yes, it should be quicker.
Okay, perfect. And then also, as more of a rural community, we currently are not in network with any of the 3 options available, human and military, but other than that, we are not in with any other plans. So for our specifics, would there be an option just for like the Medicaid plans? Okay, so we wouldn't have to
Yes.
go completely all in.
That's a great distinction that I felt to have made. We recognize that some of these players may have commercial lines or Medicare Advantage lines or other lines of service that is completely separate from the work they're doing with the SoonerSelect population. So by contracting with a plan, you are agreeing to serve our SoonerCare members through that plan. It does not mean you are also now in their commercial network. It doesn't mean you're in their Medicare Advantage network. Honestly, it means you're not that unless you choose to be, but you are only contracted with them to serve SoonerCare members as you would through us today. All right. Well, thank you. Very good, robust questions. We'll be lingering. Me and the team will be lingering out there as well. So I encourage you to go talk to our plan partners and feel free to ask questions. Oh, sorry. One more thing. Okay, so I was just told we have SoonerSelect at okhca.org. If you have any questions that you didn't get out today and you want to send them, we'll have a team answer that. And we have a Q&A document on our SoonerSelect page that we update regularly. And I think we might have some follow-ups.
I found out the answers to your questions regarding the PBM. It is a contractor choice to have a PBM, and that is their choice of vendor, whoever they choose. And then on the OSIS question, there is a contractual requirement to coordinate with the state health department for OSIS, whoever that question was, and a data requirement, reporting requirement is one of those.
Thanks for coming, everyone. Great turnout.